there's not always a family history. It does run in some families, and if you have family history of prostate cancer, you're going to have more chances of developing prostate cancer. Also, we see it in certain populations, especially in African American and Latino and Hispanic men. There is a higher incidence of prostate cancer. And as far as the other issues, we're not sure if other risk factors in the environment or sexually transmitted diseases actually increase the risk, but it could be related to other behaviors and lifestyle. So in 2023, the majority of prostate cancer nowadays, thankfully to the PSA test, which is the blood test that we have available, we find a lot of these cancers as a result of just regular checkups with your doctor. They'll find that you have a PSA that's slightly elevated, and they will refer you for additional testing. So as of now, men over the age of 50 should have a yearly PSA. But if you have a family history, or if you're Hispanic or African American, there's higher risk you're going to be screened at an earlier age. So again, we talked about screening. That's when you're just having the regular checkups, not necessarily having any symptoms. And then more treatment or more tests can be ordered from that. So, so once we have determined that somebody has had an elevated PSA, and we are concerned that there may be something in the prostate, either the urologist or one of your doctors felt something in the prostate, they may have ordered an MRI to look at the prostate to see if there's any abnormalities. Then a biopsy would be recommended. So there are two ways of doing the biopsy. One is through the rectum, and the other one is through the perineum. The perineum is the skin in between the testicles and the anus. And so we could put a needle in there with ultrasound guidance and send that to the pathologist so they can look at it on the microscope and tell us if it is prostate cancer and what are the characteristics of this cancer. So the gold standard for diagnosis, definitely you have to have a biopsy. So once we have a diagnosis, then we can stage it. And the way of staging it, but the most important thing is to know what's called the Gleason score. So the Gleason score is when the pathologists are looking at it in the microscope, they can see how aggressive the cancer cells look. If you have a Gleason score of 6 or below, it is considered low risk. If you have a Gleason score of 7, it's considered intermediate. And if you have a Gleason score of 8 or 9, it is considered to be high risk. Now, that just tells us about the aggressiveness of the cancer, but then we have to do other MRI or other tests to see if he has spread to the lymph nodes or the bone so that we can stage it appropriately. So again, just talking about how we stage it and making sure that it hasn't spread. So there are risk groups, and we divided between low or very low, intermediate, as I had mentioned, and high risk. So I'm not going to go over this again, but just as a reminder that depending on the risk group, that's some of the options of treatment may change. So what are those treatment options? So sometimes it can get a little bit confusing for men because there's so many different treatment options and so much information that it can get overwhelming. But the most important thing to analyze if somebody's going to need treatment is, first of all, we need to get to know the patient. We need to know what other medical conditions the patient may have. We need to know if the patient is active, if somebody that is, working and, goes to the gym or plays golf, or somebody that's retired, but still a very active person. we need to know more about the person in order to be able to recommend treatment. If it's a very low risk prostate cancer, so we're talking usually about a Gleason 6, you know, just watching it, something called active surveillance may be a good option for some men. So it is a decision that has to be taken carefully between the physician and the patient. The patient needs to be monitored. Where active surveillance doesn't mean do nothing. It means actively watching the patient. So you'll have to be seeing the doctor on a regular basis, having PSAs drawn a little bit more often, and have other tests as needed to make sure that the prostate cancer is not getting any worse. But that could be a very good option for certain people, particularly the ones with very low risk. But surveillance may not be something that some patients want to do. Some people cannot deal with the idea that they have prostate cancer and they're not doing anything about it. So if they're motivated to proceed with treatment, then we typically talk about the two most studied and reputable forms of treatment, which are going to be either surgery or some form of radiation therapy. Those are the really truly proven two ways of treating prostate cancer. There are other options, but I'm not going to touch much about them because they're really not have been proven significantly, and they're not really utilized in the United States. But so mainly surgery and radiation therapy are the most effective forms of treatment. So we've already talked a little bit about, you know, the active surveillance, and let's move on to surgery. So surgery is an excellent treatment. It has been around for many years. The urologists are now able to do surgery in a more limited fashion. They're able to do this with the assistance of a robot. So it's minimally invasive. Still have to be in the hospital for a couple of days. You may need to have a catheter in your bladder. Of course, anytime you go to have surgery, you have risks of anesthesia, risk of pain, bleeding, infection, but it's a very good treatment. The most common side effects is urinary incontinence. So there's leakage of urine, even in the most experienced hands, and even if you're using the robot, there's still a chance that there's going to be a chance that you're going to need to wear a pad. There could be sexual side effects, so there could be problems with impotence. So those are the most common risks associated with surgery, but it's a very, very good treatment. Radiation therapy. So there's different forms of radiation therapy. I think, yeah, there's different forms of radiation therapy. The most common that we're seeing in 2023 is some form of external radiation. So radiation that's delivered from a machine, like from the outside of the body going inside. And that's the most common type of radiation we utilize these days. It is very safe, very precise. Our modern computers and modern X-ray capabilities allow us to do the treatments very precisely in a very short period of time. But it is an inconvenience. It is a daily treatment. We are now reducing the number of treatments. Used to be 9 weeks. We're now doing less and less treatments. It does have side effects. There could be irritation of the bladder. That's probably the most common side effect, irritation of the bladder. There could be some burning sensation when you urinate. There can be more frequency or urgency. Those are very common side effects. There could be irritation of the rectum. Sometimes there could be a little bit of mucus production or diarrhea. And there could also be the risk of impotence. Leakage of urine is very rare after radiotherapy, even though this slide says that leakage of urine is very rare. It's more common after surgery, but it's very rare after radiation. But surgery is no better than radiation, but radiation is no better than surgery. So in other words, they're equally effective. So it is just a very personal decision on what form of treatment the patient is willing to have. And everybody has personal preferences. Everybody deals with these situations differently. The important thing is to have a good conversation with your physician as far as which option of treatment would be better for you based on your particular situation, other health conditions, and your particular preferences. There is other forms of radiation therapy called brachytherapy. So that's internal radiation. Some of you may have heard about this called the seeds. And that's also a very, very good treatment. It's just as good as well. We're not doing that much of it anymore, but there's a few centers around the country that are doing it. It is an excellent treatment. It is still invasive. There's risk of pain, bleeding, infection, irritation of the bladder. That's probably the most common issue with brachytherapy. And there could be some risk with the bowel, although it's not as much. So it's a very good treatment, but for many different reasons, it's not done very commonly in many places anymore, but it's a very good treatment. So again, a little bit talking a little bit more about radiation. I think we talked about those issues. Let me go back to talk about external beam radiation. So external beam radiation, we don't use 3D conformal radiation anymore. That's obsolete for prostate cancer. The majority of treatments now, external beam should be with what's called intensity modulated radiation, which is a very precise form of doing the treatment, or with stereotactic body radiotherapy. Proton beam is a different kind of radiation. It has also been studied for the use of prostate cancer. Unfortunately, to date, it has not been proven to be any better than intensity modulated radiation. Side effects are the same. It still takes multiple weeks to do it. And again, to this date, it has not been proven to be any better than intensity modulated radiation, and is more expensive and it's not available everywhere. So it is still not the standard of care. Some people may need to take hormonal therapy, depending on the aggressiveness of the cancer, and they may need to take something to block the testosterone. The other options are for more advanced cancer or other options that I don't recommend. So when we're talking about treating prostate cancer, and then at this point we're going to move a little bit more to the radiation therapy side of things, even though I've been very clear with you that radiation therapy is not the only answer. It is just one of the options. Surgery is a very good option as well, depending on the patient situation. So when we're doing radiation, obviously our intent is to give the maximum amount of radiation, the necessary amount of radiation, I should say, to the prostate, while minimizing the amount of radiation that you give to the surrounding organs. But unfortunately, because they're so close to the prostate is so close to the bladder and the rectum, there can be some side effects. Even with protons, there can be side effects. So the most important thing for us is to try to minimize the radiation dose that reaches the rectum or the prostate. And the rectum is considered to be an organ at risk, because that is where radiation could go if we're not careful. So it's not uncommon for some men that undergo radiotherapy that they may have, as I said, a little bit of irritation of the rectum, some hemorrhoid type sensation. They may have some mucus production and diarrhea. So we want to try to minimize those effects. And with the current technology that we have available, we can do a very, very nice job at minimizing the amount of radiation that reaches the rectum, and it's very safe and precise. Unfortunately, up to recently, men that were getting radiation were getting once a day radiation for 9 weeks, and that was extremely inconvenient and if you can imagine how disruptive that is for somebody's life to having to go for treatment for almost a couple of months. And so it is extremely inconvenient, and transportation costs and all the stress and things that come associated with going to a radiation treatment center. But it's very good because we can protect the rectum. But when we're trying to reduce the number of treatments, so now that we're trying to do less treatments, there has been some study regarding the utilization of a hydrogel. So it is a gel that is soluble in water. That's called a hydrogel. And by utilizing this hydrogel, you form an artificial space in between the prostate and the rectum, and that has been shown to decrease the chances of having inflammation to the rectum. I just lost my light, so I'm going to take a second to see if I can readjust it so you can see me better, hopefully. And my apologies for that. I think we're going to get it here. Okay, so we'll make it work. So we use that spacer to limit the exposure of the rectum to radiation, and that has been a very good product to utilize to help us protect the rectum in a better way. So there have been several studies utilizing this, and you can see in the illustration here on the right. So you have the prostate here, and the rectum is directly behind it. So we inject this gel under local anesthesia. We put it, it's similar to the biopsy. We inject it through the perineum, which is again the skin in between the testicles and the rectum. That's a very sensitive area, but we numb it down very good. And then we place those, we place some markers in the prostate, and then we inject the gel and watch it with ultrasound to make sure that it's in the correct positioning. So it's a very safe procedure, and it does help create a space so that the radiation dose doesn't reach the prostate and minimizes side effects. Again, the technology with radiotherapy is so good that we can protect the rectum quite well, but now that we're trying to do less and less treatments, in some men, this could be an important addition to the treatment to prevent side effects. So there are fewer bowel complications, particularly when you're doing it a shorter period of time, and there may be some less chance of urinary complications as well. So the SpaceOAR is being used in many centers across the country, and we can do it as it's an outpatient procedure. Takes about 30 to 45 minutes to do it. It's generally well tolerated, and the men can go back to their normal routine after that. The only thing we need to do is just ask them to make sure that they're not taking a blood thinner, because it's an invasive procedure. So we may need to, we just worry about that they could have a little bit of bleeding if they're taking a blood thinner. And we just have them take an antibiotic to prevent any infections. But it's again really well tolerated. We put an ultrasound in the rectum, and we make sure that we're placing the gel in the correct position. So it's like done in real time, making sure that we are able to visualize the area where the gel is being placed. And once that has been done, then we can move on and proceed with the actual planning of the radiation therapy treatment. I think there's a video there, but I'm gonna skip that because I think that it's important to have a good conversation with your doctor and make sure that this would be something that would reduce the risks and that would help you tolerate the radiation treatment a little bit better. So, so in summary, there's different options for the treatment of prostate cancer. It is a patient preference based on the characteristics of your cancer. All of the options have side effects, including, watchful waiting. I mean, obviously it's not a treatment, but there could be anxiety, and there could be cost associated with repeated PSAs and repeated visits to the doctor, even if you're just watching this. The prostate is in very close proximity to the rectum and the bladder. So unintentionally, there could be a little bit of radiation dose that can reach the bladder or the rectum, and there could be some side effects. And the use of a hydrogel can or does create a space there that may reduce the side effects, and some of the patients may benefit from the utilization of this product. So again, just make sure that you know your risk level. Talk to your doctor about being checked regularly, especially if you have a family history of prostate cancer. Make sure that you don't skip those tests once a year, and evaluate closely what options you want. I think there's some resources there, the American Cancer Society, the Zero Prostate Cancer, and the Prostate Health Education, and also some additional information there on the website for SpaceOAR.com. So I think it was a brief overview, but I think that we can, with that introduction about treatment options, we can expand a little bit more and ask questions that maybe were not clarified during the presentation. So I'm going to open it up to questions.